Now, a couple of definitions that become important for us. We are a tachy, so it has to be above 100. Put you in the category. If it's less than 100, and the P wave looks abnormal, and I'll tell you what this abnormality of the P wave is in a second. Be careful because remember, if you find an EKG, and here I'm gonna push you a little bit, okay? But you can handle it. If you take a look at an EKG, you're going to look for a P wave preceding the QRS complex, an upright QRS complex, especially lead 2, and that then gives you sinus type of rhythm. You'll take a look at a rate, take a look at axis deviation, and that P wave should be, well, as you would expect, a P wave. However, when I show you the P wave upcoming, you'll notice that the P wave is going to look rather dysmorphic, okay? Not fibrillated, not fluttered, meaning sawtooth, but fibrillated, or in other words, it's wandering. It is going to look dysmorphic. If you find a dysmorphic type of P wave, and you find the heart rate to be almost within normal range, you will not call it multi-atrial tachycardia. You will call it wandering atrial pacemaker. It really comes down to a simple definition such as less than 100 beats per minute. Next, what about the ECGs? Well, see, now we get into a dysmorphic or P waves in which its morphology has been altered. And when I show it to you, it'll be quite obvious. But before we get there, though, a couple other definitions that you want to keep in mind. In one strip of EKG, on the same lead, you need to find at least 3 distinct P waves. And by distinct, I do not mean wave, like fibrillation. I don't mean tooth, like sawtooth. No. 3 distinct. Each P wave looks a little bit more different than the other. So rather distinct in morphology. Of whom? The P wave. Do not touch the QRS complex because this is SVT. Hope that's clear. Spend a little bit of time with that last bullet point there because that really is going to be the description or the distinguishing point in words of an SVT known as multifocal atrial tachycardia. And then less than 100 beats per minute would be your wandering atrial pacemaker. What do you want to do? You correct the underlying issue of verapamil. Now, in terms of drugs, up until now, when we try to control that rhythm, we try to cardiovert, and we can do our cardioversion by medicine or medical cardioversion. And if that is not effective, your next step of management would have to be electrical cardioversion, right? When we did our other SVTs, including AFib and atrial flutter, we try to cardiovert medically. And we did so by slowing things down. We did that by giving digoxin. We did that by giving metoprolol, a beta blocker, right? Now, verapamil, which is a calcium channel blocker, much more specific for the heart, think V verapamil, V ventricle, it slows down the heart rate. Or it tries to convert your abnormal, distinct P wave into a proper, normal sinus rhythm. Is that clear? Do you understand the concept of cardioversion now? Now, if it is calcium channel blocker, you're trying to control that heart rate, well, let me one more time bring this up, and I'm going to keep reinforcing this until you fully understand when you do pharmacology with antiarrhythmics as to what you're dealing with. Earlier, when we were talking about SVTs, and I was talking to you about that phase 403, because we're talking about heart rate, which would be the pacemaker. That phase 4, which was funny, with the sodium channel, I told you specifically that has to be ligand gated, and the only effective, or should I say a more effective antiarrhythmic class that would work on that phase 4 was that class 2, which was a beta blocker. Dr. Raj, really, it's not making sense. It's not sticking. Well, yeah, it has already, believe it or not. When you did autonomic nervous system, when you did CNS physiology, you looked at the autonomic nervous system and you looked at parasympathetic nervous system. How do you slow down that heart rate? Can you picture that? 403, parasympathetic, acetylcholine, working on M2 receptors on the heart. And how do you slow down that heart rate? By causing a decreased gradient of phase 4. Are you seeing this? And if you're not, listen to what I'm saying. Go draw it out or go look at it where you take a look at your action potential and slowing down of your heart rate parasympathetic, and you worked through your phase 4. Is that clear? Acetylcholine. That has to be ligand gated. Isn't that clear? That has to be clear. It has to be clear. Now, that was when we're dealing with phase 4. So now let's talk about phase 0 of your pacemaker, heart rate. What is phase 0 as a pacemaker? You see as to how we're integrating stuff? Stick with me here. Phase 0 in a pacemaker potential is going to be your calcium channel. Okay? So therefore, a drug or class of antiarrhythmics that might work here would be something like a calcium channel blocker, huh? Let's continue. What other drugs? Well, beta blockers to a certain extent could be used. Same concept. You're trying to slow down that heart rate. What phase? Phase 4. You know that. It decreases heart rate. And do not use a DIG in the treatment of MAT, though. Okay, that's important. Multifocal atrial tachycardia. There are too many other factors that are in play in which digoxin might actually not be effective. Keep that in mind. Whereas digoxin was a drug that you're definitely thinking about using or considering when dealing with AFib and atrial flutter. That's another huge distinction point, that last bullet point right there with digoxin. Hope that's clear. Let's continue. So, I want you to take a look at the bottom ECG lead, and with that strip, you're paying attention to the P wave. Does that look fibrillated to you? So what you're doing now, when you're going through this lecture series with SVTs, supraventricular tachycardia, is comparing atrial fibrillation, atrial flutter, and now multifocal atrial tachycardia. Please do that for me. It's the best way to then identify each one. The P wave is not fibrillated. It's definitely not sawtooth. And on the same lead, you'll find 3 different rhythms in which the P wave is rather distinct, even within the same lead. This then gives you multifocal atrial tachycardia with a beat per minute or heart rate above 100, tachy. If by chance it falls below 100, then you start thinking about the alternate diagnosis of wandering atrial pacemaker. Let's continue.